Hypothyroidism doesn't tell us what the cause is. We have to ask ourselves, why is the TSH high? Why is the T4 low? And everyone is gonna be a little bit different. Hey everyone, Dr. Bodle here. Now, something that I think is really important for all people with thyroid symptoms to know is that the key to helping you get better is understanding your diagnosis. But at the same time, using the diagnosis of hypothyroidism probably isn't going to get you there. And the reason being is that hypothyroidism isn't a good diagnosis in and of itself. It's only a description of your symptoms and lab values, and it really doesn't tell us what is going on underneath the surface. Now, for many people, the cause of their hypothyroidism is due to an autoimmune condition called Hashimoto's. But even if we've identified that in your particular case, we still have to take things one step further. When it comes to healing and supporting someone who is having symptoms due to autoimmunity, we always want to identify what are the immune triggers, how can we manage them, and how can we support the parts of the body that have been impacted. So whenever I have a new patient, I'm always asking myself, where's the fire? How can we put it out? And how can we rebuild and repair the parts of the town that were impacted? So in today's video, we're gonna go behind the scenes a little bit and run through a real set of blood labs together, talk about the potential contributing factors to Hashimoto's. That way you can start to understand the thought process that goes into these things, and hopefully you can start to apply that to your own life. And real quickly, if you find this kind of information to be helpful and would like to support the channel, please remember to like and subscribe. That way we can continue to discuss these natural strategies and options for you to help support your Hashimoto's and your hypothyroidism. That way you can feel your best and get back to living your life. But before we get into the labs, I wanted to circle back to some of the things that I mentioned in the intro. That way you guys have a little bit more context when we start going through some of those numbers. So as I said, hypothyroidism is not a great diagnosis. And if you've watched some of my stuff before, you've heard me compare hypothyroidism to someone getting the diagnosis of knee pain. So just to go over that one more time, if you injured your knee and you went into your doctor, you would want them to tell you why your knee was giving you pain. And the reason for this is, one, you want to know what sort of direction you need to go in, but that's important for us because we want the treatment or the application to match the cause of your pain. So you go into your doctor, you want them to be able to tell you, oh, this is a meniscus, or this is an ACL, or this is a sprain. Because again, those types of things are going to demand different types of responses. But if your doctor just says, hey, your diagnosis is knee pain, well, you already knew that. That's just a description of what's going on, and it doesn't tell us what we actually need to address. So in a similar way, hypothyroidism is just about checking boxes. Do you have an increase in TSH and low T4? Check, check. And do you have low thyroid symptoms? The things that we're all familiar with. Fatigue, weight gain, hair loss, brittle nails, constipation and gut changes, anything that is associated with a slowdown in metabolism. But once those boxes are checked, it doesn't seem like there's a lot more investigation that goes into it. Usually people are prescribed some sort of T4 medication and they're shuttled out the door, and that's the end of it. But as I said in the beginning of the video, hypothyroidism doesn't tell us what the cause is. We have to ask ourselves, why is the TSH high? Why is the T4 low? And everyone is going to be a little bit different. And if we can better identify what the individual needs, then we can choose things that are specific to that person. That way they can actually start healing and feeling better again. So just like with our knee, if we tore our ACL, we probably need surgery. But if we sprained our knee, then we probably just need to ice and rest. And if we were to give someone who only sprained their knee and needs rest a big time surgery, they're not going to feel better, and we've done more harm than good. Now, something that I encourage a lot of people to do is to get their thyroid antibodies checked. And this includes TPO antibodies and also thyroglobulin antibodies. And this can be helpful in two different situations. The first situation is someone who's been diagnosed with hypothyroidism, so they have that high TSH and low T4, but they're continuing to struggle with symptoms, or the medication that they're taking really hasn't made much of a difference for them. And the other situation is someone who is having a lot of thyroid symptoms, but their TSH is normal and their T4 is normal, and their doctor doesn't really know what's going on. In either one of these scenarios, whether we have enough thyroid hormone in the system because our body's still making enough, or because we're now taking medication, the presence of antibodies can interrupt our body's ability to utilize thyroid hormone. And even though enough is present in the system, if we don't use it properly, we're not going to get that normal function that we would expect. These antibody markers are diagnostic for Hashimoto's. And whether we're in those early stages where the antibodies are present but the other standard lab values for our thyroid look normal, or we're in those later stages where, again, antibodies are still present but now we might have an increased need for medication, these antibodies are something that are critical for us to identify. And while not everyone who has hypothyroidism also has Hashimoto's, it is one of the most common causes, so it's something that we need to check into. But with that all said, even saying someone has Hashimoto's still probably isn't enough. And there's going to be unique differences from person to person in the way that we need to support them and help their healing. That's why when I'm trying to assess these situations, I want to look at all the big contributing factors that could irritate and stress our immune system. And that can include things like food sensitivities and reactions, gut dysfunction, problems with our liver and gallbladder pathways, hormonal imbalances, blood sugar dysregulation, nutrient deficiencies, chronic infections, decreased quality and duration of sleep, and chronic stress. Now, this list isn't completely exhaustive, but it does cover the vast majority of issues that you might be dealing with. And if there are other things beyond this list, this at the very least gives you some good starting points, and there's probably going to be a few things here that you need to work on to at least get things moving in the right direction. Now, I would like to point out that we've talked before about how autoimmunity tends to develop due to three main factors. And that includes a genetic predisposition towards the disease, if I can say disposition right, a breakdown in our barrier systems, including things like our lung, gut, skin, and brain, and then also a triggering or initiating event. Now, these things can be really important for us to understand, but I did want to make the point that sometimes the initial triggering event can be the thing that is continuing to perpetuate and trigger our symptoms, and sometimes it's something completely different. For example, let's say you started a new job and it was super high stress. And looking back, you see that there's a correlation between the timing of starting that new job and also the development of a lot of your symptoms. Well, it's certainly possible that that work environment and that work stress led to a change in the way that your immune system functions and therefore led to the development of autoimmunity. But then we'd have to ask ourselves, are you in the same position? If so, then it's likely that that work stress that caused things to kick off in the first place is still contributing to your symptoms now. However, if you've moved on from that position and you're still having challenges with your health, then we need to start looking at other potential contributing factors that we can manage and reduce some of that stress on your body. Again, both are important, but I just want you to keep in mind that the initiating factor and the perpetuating factor may or may not be the same thing. And if we were to bring it back to something more structural in nature, which I think is sometimes an easier way to think about things, let's say you sprained your ankle and were in a boot for an extended period of time. Well, while you were walking in that boot, that could have changed the way that your low back and hips move, and that could then lead to the onset of low back pain. Now, of course, eventually that boot is going to be gone, but is the low back pain remaining? Well, it's possible that it could. But by now, it might not be due to the boot, because it's no longer there, but maybe we had some changes in low back strength or mobility, and because of that initial factor that led to these downstream issues, we now have to do some different things to rehab to get us feeling better, both in our ankle and in our low back. But let's actually get into the labs as I promised. And if there was any question, This is a real set of labs. We're going to go through it just like I would in practice. And as we're working through this stuff, I want you to be aware that although labs are super important and I use them all the time, if you're a patient who's coming into my clinic, we're getting some labs done. Might look a little bit different from person to person, but that's a piece of the assessment process. But labs, for as many benefits as they have, they are limited. They're only a snapshot of what your health looks like at a particular time. And although they provide us with a lot of good information, we have to make sure that we assess them within the context of your health and your symptoms. As I often say to a lot of my patients, I would rather have you have perfect function rather than perfect labs. Meaning that the labs should add to what we're doing for your health rather than being the final say for whether you're healthy or not. Also, severity of a lab marker doesn't always perfectly correlate with the severity of your symptoms. So if you have something that is abnormal and you know someone else who has the same marker that's abnormal, if yours is more or less than that person, it doesn't mean that you're better or worse. Lab markers, again, limited in some ways, and it doesn't always tell the full picture of our physiology. So I say this just as another reinforcing factor that history, examination, labs, all of these things need to go together. That way we can really develop that full picture for what you need as a person. So as we work through our blood panel, we want to keep some of those triggers for autoimmunity in the back of our head. And the nice thing is, the first thing on most blood labs is going to be our fasting glucose and our hemoglobin A1C. And we said that blood sugar dysregulation can be one of those things that promotes inflammation and can make our Hashimoto's worse. So for this particular patient, her fasting glucose is 97 milligrams per deciliter, and her hemoglobin A1C is lab high at 5.9. The range there typically being 4.8 to 5.6. Now, a lot of times people ask me, well, Dr. Brad, how can I have normal fasting glucose but an elevation in my average glucose or an elevation in the hemoglobin A1C? And the reason for this is due to the fact that most people with this type of presentation do not have stable blood sugar throughout the day. What that means is there's going to be intermittent spikes or elevation with our blood sugar, which when we fast, the fasting glucose looks fine, but because it's functionally not stable for us, there's enough of a change that it will pull that average up over a 24-hour period and certainly over a multi-month period, which our hemoglobin A1C looks at. But once we see some abnormalities in our blood sugar markers, I want to instantly go take a look at what our lipid panel looks like. So as we flip to the next page, we look at the cholesterol, and the total cholesterol is lab high at 235, and the triglycerides are lab high at 190. Now, I'm not a big cholesterol guy. I know there are people out there who look at cholesterol solely as an indicator for cardiovascular risk, and they want to do everything they can to get that cholesterol down. And there certainly are situations where that might be warranted. However, whenever I'm looking at cholesterol, I'm always wondering, what is driving that increase in cholesterol? Just like we talked about what is driving our thyroid symptoms. So many times when we have excess levels of glucose in the bloodstream, our body doesn't like that. It knows that high levels of blood sugar can be problematic for us. And so it will do its best to mitigate or manage that. Much of the time, it will take, specifically through liver pathways, it'll take that excess glucose and it will convert it or turn it into triglycerides. These triglycerides are then moved to fat cells, either through the bloodstream by themselves, or more efficiently, through the use of lipoproteins. Now, most people aren't familiar with the term lipoproteins, but you actually do know what that is. So whenever we say LDL or HDL, LDL cholesterol really stands for low density lipoprotein, and HDL stands for high density lipoprotein. These lipoproteins are essentially transport structures that have cholesterol as part of their makeup, as part of their structure. And since fat doesn't mix well with water, one of the better or more efficient ways to transport some of these triglycerides is by packaging them into lipoproteins and then using those lipoproteins to drop them off at the appropriate cells. Without getting into too much detail, LDL cholesterol is typically the marker that represents those lipoproteins that transports fats from the liver to our cells. And when we look at the labs here, we see that the LDL cholesterol is also elevated. It's at 138, and usually we like it to be under 100 milligrams per deciliter. So although cholesterol can be elevated for a number of reasons, and I think it's important for us to consider the fact that immune system activation, inflammation, decreased ability to clear our cholesterol, all of which can be related directly to autoimmunity and Hashimoto's. Those are important things for us to consider, but it could also be to some of these issues with our blood sugar. So the fact that the hemoglobin A1C is high, we're also seeing high levels of triglycerides. Now the LDL cholesterol is high and therefore the total cholesterol is high. All of that starts to paint this clinical picture that blood sugar might be something that we want to work on if it correlates well with our symptoms. Next, we're going to go back to the first page and work our way through some of these additional markers. On this particular lab set, uric acid is the next marker. It looks fine, although I'm often checking that one if it's elevated as a sign of inflammation. Many times people associate uric acid with gout, and that's a good way to think about it. People who have gout do have elevated levels of uric acid, but people can also have increased uric acid and not have gout. When we're looking at that marker and we're thinking about inflammation, many times people can have an increase in generalized joint pain or fatigability, and that can be a reflection of it. We then have a few different kidney markers. For this patient, filtration rate, the GFR, glomerular filtration rate, looks totally fine, and there's no changes in blood urea nitrogen or creatinine. Next comes electrolytes and some of our micronutrients. These also all look fine, the big ones being sodium, potassium, chloride, and magnesium. But I do like to point out that electrolytes tend to be very functional in nature. Meaning that when we look at the serum levels, most of the time, for most people, they look okay. In severe illnesses, they can start to shift, but again, general rule, they tend to look fine. However, that doesn't mean that someone might not benefit from taking electrolytes. We've pointed out in the past that increased levels of stress, chronic overtraining, chronic inflammation, poor hydration, all of these things can affect the way that our electrolytes and fluid balance works. So it's good to see this looking normal for us, but that doesn't necessarily rule out that someone could benefit in this area. Continue to work our way down. We have our total protein levels and also albumin and globulin. Now, when we look at the major causes of changes in these markers, it's going to be very severe conditions. Things like severe infections, potentially cancer, kidney disease, and also liver disease. So for most people, you're not going to see any big changes in these markers. But as a more functional rule, these markers can sort of shift and change in association with gut dysfunction, whether poor breakdown of food or mild inflammation. However, they can also look totally normal, and that doesn't mean that we aren't having any issues with our gut. So it follows that same idea as we talked about with our electrolytes, in that they might look fine on the labs, but that doesn't mean that that isn't an area that we need to support and make sure that it is improving as part of our overall health picture. Speaking of liver disease, the next section has a little bit more focus on that part of the body, although these enzymes are not necessarily specific to our liver. It just tends to be more commonly associated with it. Now, for our patient, the markers look relatively good, although there is a mild elevation in ALT. So the range there is 0 to 32 international units per liter, and her ALT is at 46. So when it comes to assessing enzymes, enzymes normally should be within our cells. And when they're suddenly in the bloodstream in high levels, it means that there's some sort of damage occurring on a tissue level, which is then causing those cells to break open and kind of spill their contents or their guts into the bloodstream. So when we look at LDH, AST, and ALT, we always want to think about, okay, what cells in the body have these enzymes present in them? And then if they're high, what sort of symptoms are we having that we can correlate and better target where they might be coming from? So if there was an increase in LDH, for example, we might be thinking, how's our liver? How's our kidney? How's our heart? Are we having any muscle issues? Are we having any anemia? And we want to have a similar thought process for AST and ALT. Now again, just because the ALT is high in this scenario, we don't know exactly where that's coming from, but because of the increase in blood sugar and triglycerides, it wouldn't be unusual that this particular person is having a little bit of fatty accumulation on the liver, and that's contributing to some of that irritation and therefore that cell damage. Also grouped here is the enzyme GGT, which is also found throughout the body, but tends to be more common in our liver, in our bile ducts, and also in our gallbladder. So many times you'll hear people referring to GGT as being associated with our gallbladder, but there can be a little bit of crossover there as well. In our patient's case, her value for GGT is 12. The range there is 0 to 60, and she doesn't have any signs of issues with fat absorption or digestion, so it's not something that we're going to worry about at this time. So real quickly, just so we're on the same page, so far we have some changes in blood sugar markers that are likely contributing to changes in cholesterol and triglyceride values, and also potentially contributing to an increase in ALT. The proteins associated with our gut, some of the markers associated with our kidney and our gallbladder, all of those things look fine. So far, we want to keep in mind blood sugar and fuel, how can we help to support that? And potentially maybe some changes in the way that our liver and detox pathways are working, but there isn't anything overt suggesting that right now. Next is one of my favorite sections to talk about, which is iron markers. And I've spent a lot of time going over this, so if you want a video just on iron markers and anemia, I will link it for you in the cards above. But the reason why I like talking about iron is because I feel like this is something that's super important for us, and that's backed up not just because of my feelings, but because of the research. We know that the enzymes in our thyroid gland are heme or iron dependent, and there's research that shows that people with appropriate levels of thyroid hormone or with appropriate medication application still don't get better until they have proper iron stores resolved through some type of supplementation or some sort of infusion. So this is a big deal to me. I think it's a big deal to my patients. And again, I think it gets missed all the time. So when we're assessing iron, there's a few different markers for us to look at. And those include iron binding capacity or total iron binding capacity, serum iron, iron saturation, and ferritin. And I think because these markers can shift around on us, we really need to look at all of them to be able to be kind of as specific and accurate as possible. Now, with iron binding capacity, this is a marker that typically increases when we need iron. So I think of it as the body trying to grab onto more iron because it's in need of it. Its binding capacity goes up. It's trying to get more into the system. The range for iron binding capacity is 250 to 450 micrograms per deciliter, but anytime we're above 350, I start to kind of look at that and wonder, hey, do we have any potential issues with our iron? And for this patient, the value is 360. Then we're going to look at serum iron. Range there is 27 to 159 micrograms per deciliter. And this patient's total is 74. So right in the middle there. Iron saturation is a percentage of iron bound to protein. This range is 15 to 55, and this patient's iron saturation is 22. So again, a little bit on the lower end there, but not too bad. And finally, ferritin, which most people kind of hang their hat on as being the best way to look at iron. We want to remember that ferritin is not iron itself. It's actually a protein that binds iron, and binding iron is only one of its jobs. So we need to keep all of its jobs in mind when we're looking at it. Now the range for ferritin is 15 to 150 nanograms per milliliter, But I always like my women to be above 50 at a minimum. And you've probably heard me say before that there is some research that suggests that maybe above 60 or 70 might be more optimal. However, in this particular instance, the ferritin is coming back as 160. So the normal range is 15 to 150, and this result is 160. So what's going on here? Our iron binding capacity is slightly elevated. Our serum iron is okay. Our iron saturation is a little bit on that lower half of the range, and then our ferritin is lab high. That doesn't really make a lot of sense, does it? Some of the markers suggest that we might need more iron, and then our ferritin is suggesting that we have way too much. But this goes back to understanding the other jobs of ferritin. So ferritin is also what we call an acute phase reactant, meaning it's one of the proteins in our body that can react or respond to inflammation. This is the same reason that when you look at the research, you see that people who have infections or people who have diabetes, causes for either acute or chronic inflammation, we can no longer use ferritin as a reliable marker for iron status because the inflammation impairs, essentially, our ability to read the true value of that marker. It's no longer an indication of iron, it's now more an indication of inflammation. So does this patient have inflammation? Well, we know they have Hashimoto's, so the answer is yes, but what we don't know is how much that inflammation is impacting some of the actual lab values. So what we're going to do in a bit is we're going to compare ferritin to some of those other inflammatory markers, and that'll give us a much better idea of what's going on. With that all said, in my experience, my expectation is that this patient probably needs some iron support. They have a few different markers that are suggestive of it, and when we are inflamed and those ferritin markers get elevated, it's very common that when we decrease inflammation, those ferritin levels will dramatically drop, and we'll see that the more real representation of their iron status is that it probably wasn't very good. Sometimes it makes sense for us to go after this right away. Sometimes we'll delay it because we're unsure and we want to work on other priorities first. But because micronutrients and iron is so important to thyroid function in general, this is something that we want to add to our list and at least keep in the back of our mind. Speaking of which, what do some of those inflammatory markers look like? And when I like to assess these situations, I like to make sure that we're getting C-reactive protein high sensitivity, fibrinogen, homocysteine, and I think that vitamin D can also be a great indicator of overall inflammatory load. For our patient, the C-reactive protein high sensitivity, which ranges from 0 to 3 milligrams per liter, is 4.8. So we just said that that elevated ferritin might not be an indication of iron overload. Instead, it could be an indication of inflammation. And now we have another inflammatory marker that is lab high. As we turn the page and look at homocysteine, the range there for homocysteine is 0 to 14.5 micromoles per liter, and her result is currently 12. Now, in general, I like homocysteine to be under 10. So while this isn't lab high, it's something for us to kind of keep an eye on as we're looking at all these markers together. The next page is where we can find fibrinogen. The range there is usually about 190 to 500 milligrams per deciliter, and hers is about in the middle at 344. And finally, going back to the previous page, vitamin D range is 30 to 100 nanograms per milliliter, and hers is 24. So when we talk about inflammatory markers, I sometimes think of it like herding cats. They don't all like to go in the same direction at the same time. So what we want to do is assess kind of the overall picture, and then as part of our strategy and part of our goal to help you improve, we want to see these things start moving in the same direction. They don't all move in the same direction at the same speed, but if we can get the general trend to be positive for us, then I always think that it correlates very well with how we're feeling and how we're functioning. So here we have C-reactive protein that is lab high, we have homocysteine which is trending high, fibrinogen looks fine, and then our vitamin D is lab low. Now, we don't always know exactly what's driving these inflammatory markers. Could be the blood sugar issues that we've talked about, could be the autoimmune issues that we're going to talk about. So even if we don't have a real clear indicator or connection, we can again use it as a marker for progression. That way, as the person's improving, we can track these along the way. This is why it's so helpful to get this stuff done when a person first starts with care, because it's possible that someone might have a C-reactive protein of 10 when they start. But if you don't check that and you came back and you saw that someone was at 5, you might panic and think, oh no, we're doing the wrong thing. This person's inflamed, yada, yada, yada. But it's all about the comparison from one lab to another. And finally, we have our thyroid panel. And if someone is having thyroid symptoms and they haven't improved with the standard of care, I like to have people get a full, or sometimes it's referred to as an expanded thyroid panel. And this includes the markers of TSH, total T4, free T4, total T3, free T3, T3 uptake, reverse T3, free thyroxine index or FTI, and also TPO antibodies and TG antibodies. Now, of course, not all of these markers are going to be abnormal, but I want to check them and I want to see if there are any breakdowns in any part of your thyroid physiology. We want to be aware of it, and that way we can track it and support it if needed. For our patient today, there's a couple of areas that stand out. Now, I know I usually talk about how our body is using thyroid hormone, but it still is important to check those thyroid hormone quantities. So when we look at T4, both total and free, our T4 is 7, our free T4 is 1.2, so both of those look good. And also our T3 levels, total T3 is 135, free T3 is 2.9. Both of those look pretty good. If we were to nitpick, maybe that free T3 is a little bit on the low end, but overall, those numbers don't suggest that there's any issue there. Now, when we move on to some of our specialty markers, things like T3 uptake and reverse T3, these would give us an indication of how thyroid hormone is being bound and transported throughout the body. That's T3 uptake. And then reverse T3 gives us a little bit of an indication about how our body is converting T4 into T3. Both of these numbers look fine as well. T3 uptake is 27 and reverse T3 is 15.6. The lab range for reverse T3 is about 9 to 24 nanograms per deciliter, and I usually like it to be somewhere between 12 and 20. But again, all of that looks good. Looks like we're making enough thyroid hormone. We have both good amounts of total and free hormone. We're transporting it, and we don't seem to have an issue with conversion of T4 to T3. So what areas are we having a bit of an issue with? Well, the big one is going to be the presence of thyroid antibodies. So when we look at the labs, TPO antibodies are 128. Normal range there is 0 to 34, and that will vary depending on the lab that is doing the testing. So sometimes people will ask me like, oh, I had my labs tested before and TPO was supposed to be less than 9. Now, if I have it at 20, does that mean I'm actually positive, but because I was tested on a lab that was 0 to 34, they're not as sensitive? No, it's a different way that they're processing those results. And so you can't compare the 20 on the 0 to 34 as being the same as the 0 to 9. However, this lab is 0 to 34. Again, 128 is lab high for us. And then thyroglobulin antibodies came back as 65, and anything above 1 is considered abnormal. As a reminder, TPO and TG antibodies can also be positive in Graves' disease. But in those scenarios, you're going to have a severely suppressed TSH, and you're also going to be presenting with hyperthyroid symptoms. In this case, because the patient is having low thyroid symptoms and we have positive TPO and TG, this is indicative of Hashimoto's. But the other area that we want to look at is the marker that most commonly gets talked about with thyroid, but we haven't talked about it yet, and that's TSH. So the range for TSH is typically 0.45 to 4.5, and the reading on this lab is 0.46. So that is barely above the range, And this is one that can also throw people for a loop because usually, we talked about this with our diagnostic criteria earlier in the video, usually with hypothyroidism, you have an increase in TSH and low T4. So this pattern of a low TSH with low thyroid symptoms isn't something that's always well recognized. The thing is, in a healthy environment, if our thyroid isn't working, then our brain should recognize it and try to stimulate better output from the thyroid gland by increasing TSH. But that means we're assuming there's a healthy environment for our brain as well. So when we see this pattern of low TSH plus generally low thyroid symptoms, in this case not due to the amount of thyroid hormone, but due to the inflammation associated with the autoimmune activity and the antibodies, we now want to consider that either the health of our brain or, as I said, the environment around our brain isn't optimal, and therefore, even though our thyroid is struggling a bit, our brain doesn't have the ability to release proper amounts of TSH to kind of manage or adjust to the problem. If it does get to the point where TSH becomes low and we also have low T4 and low T3, then that is referred to as secondary hypothyroidism, and that's something else that I've made a video on and I will also link for you guys. So for this patient, we have enough thyroid hormone, no issues there. We have positive antibodies, and that can lead to an impairment of how our body uses the thyroid hormone that it has in the system. And we also have this low trending TSH, which suggests that our brain's ability to communicate with our thyroid really isn't as optimal as we'd like it to be. But let's take a step back and look at what we figured out today. So we know that we have some abnormalities with our blood sugar, which is leading to unstable fuel levels and inflammation and contributing to changes in our lipid panel and potentially with some of our liver markers. We also have a little bit of funkiness going on with our iron panel, an increase in the iron binding capacity, while we have low trending serum iron and low trending iron saturation, but high levels of ferritin. This might indicate an iron need, but it's a little bit unclear right now because of likely increases of inflammation. To go along with our thinking, we also had an increase in C-reactive protein and our homocysteine was trending high. Not to mention the fact that our vitamin D was lab low. To cap it all off, our thyroid panel wasn't horrible, but that TSH was definitely on the low end, and we also had the positive antibodies. But like we said in the beginning, having the diagnosis of Hashimoto's is important, but we want to know those contributing factors. In this scenario, we're going to want to focus on stabilizing the blood sugar and helping to improve and support some of those related markers. We also want to reduce inflammation, support vitamin D, and provide extra iron support if necessary. And finally, on top of those indications that we're able to pull from our labs, we're going to want to look at some of those nutritional and lifestyle factors that we can't necessarily get from this sort of assessment and make sure that we're doing a good thing of choosing foods that fit with the person's body, make sure they're getting consistent rest, and also managing stress and moving on a regular basis. But if we can do a good job of combining a sensible approach where we manage a lot of those nutrition and lifestyle factors, while also being very specific about the things that we found in the labs, we're going to really stack the deck in our favor and make the odds of us being able to heal and improve how we feel much more likely. But I hope that you enjoyed working through the assessment process with me today. And if you have any questions about any of the markers or concepts that we covered, just leave me a comment down below. If you like the info but feel like you need some more help and want to work with me one-on-one, you can always start that process by getting in touch with my office by sending an email to contact@seattlethyroidhelp.com. If you'd rather do some things on your own at home, you can also check out my free downloads, which are linked in the description box. But that is all for now. I love and appreciate you guys. Thank you for being here. If you want to support the channel, remember to like, subscribe, and ring the bell for notifications. If you want more information, you can follow me on Instagram or Facebook, where I post daily information and strategies about natural ways to support your thyroid. But my name is Dr. Bodle. I hope you guys have a great rest of your week, and I will see you in the next one.